The influence of the direction of LV activation on the spatial distribution of conduction slowing. Implication for substrate mapping of VT. In patients with scar-related VT, slow conduction is imposed by the interaction between collagen and cardiomyocytes in the so-called border zone. Areas of slow conduction during VT often exhibit slow conduction during sinus rhythm. This allows identifying and ablating the presumed isthmus during sinus rhythm. However, initiation of VT rarely occurs during sinus rhythm. It often depends on premature beats interacting with the infarct from a specific direction and at a specific cycle length. The figure, taken from the work of Gil Jense and Jacques de Bacca, explains the concept of anisotropic conduction. As we can see, pacing perpendicular to the fiber orientation from point A result in significant conduction slowing up to a block. On the other hand, when conduction runs parallel to fiber orientation from point B, there is minimal conduction delay. This suggests that conduction slowing may not always be revealed during sinus rhythm. The scientific question is, does activation slowing during sinus rhythm sufficiently sensitive to identify all potential isthmus sites, or can these only be revealed by stimulation from different directions and at specific range of cycle lengths because of anisotropic properties of the arrhythmogenic substrate? The aim of the present study was to examine the influence of the direction and coupling interval of LV activation on the spatial distribution and magnitude of activation slowing. This was done in a porcine model of healed infarction. In ten swine with healed anterior infarction, the LV was mapped using Cardio-3 and the Octave multi-electrode catheter. The catheter has 48 electrodes, each 1 mm in diameter, and an inter-electrode spacing of 2 mm. LV mapping was done from three different wavefronts: atrial pacing, RV and LV pacing, and at two cycle lengths, 500 milliseconds and VERB plus 30 milliseconds. Activation slowing was defined as conduction of less than 40 milliseconds per 1 cm distance in the vector of propagation. For each map, area of maximal activation slowing was marked individually. Following completion of mapping, VT was induced with electrical stimulation and were mapped with activation or entrainment. The following figure shows the influence of wavefront direction on the area of maximal activation slowing. The panels show voltage maps and corresponding activation map during atrial pacing. The area of maximal slowing, marked by the white line, is located on the first interaction of the wavefront with the infarct on the superior septal aspect of the scar. The middle panels show voltage and activation maps during RV pacing. In this case, although the scar appears similar on voltage maps, the area of maximal slowing occurs in the apico-septal aspect of the scar, where the wavefront first interacts with the scar. Notice that the area of maximal slowing is different from the one seen in the previous pacing site, though they do partially overlap. The right panels show the maps from LV pacing. The maximal slowing is once more located to the first interaction of the wavefront with the scar. This area was not seen in both atrial or RV pacing maps. Note that the bipolar voltage is similar in all three pacing sites. We can also see that the areas of maximal slowing are in regions where normal voltage becomes very low, usually under 0.5 mV. In essence, there is a dynamic nature to the area of maximal slowing. The direction of activation determines the site of slowing, when the area of slowing will usually be located to the first interaction of the wavefront with the infarction. Next, we looked at the effect of coupling interval on conduction. In the figure, all maps are in the same orientation. Left panels show CS pacing maps, middle panels show RV pacing maps, and the right panels show the lateral LV pacing maps. For each pacing site, two coupling intervals are shown, 600 and 300 milliseconds. The panels are colored with green, white, and red as a tribute to our colleagues from Italy in this dire time of COVID-19. Notice again that the scar area looks similar throughout all voltage maps. When looking at the activation maps, we notice that the pacing at a faster coupling interval does not change the location of the area of maximal slowing, but it does changes the magnitude of the conduction slowing. This finding can be also seen in this example. In comparison to S1 pacing at 500 milliseconds, pacing at a shorter coupling interval in S2 and S3 shows significant slower conduction. In this example of reentered VT with a cycle length of 288 milliseconds, the isthmus appears to be located on the lateral aspect of the LV. The isthmus during VT colocalized to the area of maximal activation slowing during lateral LV pacing, but not to the one during atrial pacing. In fact, in the present study, from 18 VTs induced, 16 isthmus sites colocalized with regions of maximal slowing identified during stimulation from a single or multiple sites. In contrast, only 10 isthmus sites were localized to areas of maximal slowing during atrial pacing. To conclude, the direction of activation determines the site of maximal activation slowing. This frequently occurred in areas transitioning from normal bipolar voltage amplitude to values less than 0.5 millivolts. The coupling interval influences the magnitude of slowing and to a lesser degree the area of slowing. VT isthmus sites occur in area of activation slowing. However, these may not all be identified during sinus rhythm, but require mapping of the LV from multiple directions. Thank you for listening.